Hello everybody. So today we are going to discuss the management of class 3 malocclusions. In our last lecture we had looked at the management of class 2 malocclusion. Now at the end of this topic the student should be able to explain and recognize Engel's class 3 malocclusion and the clinical features and explain the etiology of class 3 malocclusions. Students should be able to differentiate between the various types of class 3 malocclusions, and they should be able to explain the treatment approaches to class 3 malocclusions at various stages of development. Now, a class 3 malocclusion is the least common type of malocclusion in many communities. The variation, the incidence is about less than 5%, and this incidence shows a strong ethnic variation. The highest incidence has been noted among the Japanese, around 5 to 10%, and the Koreans, and is less common among the Caucasians at about 3%. Now, what is a class 3 malocclusion? Now, when a class 3 malocclusion is when two or more of the lower incisal edges occlude in front or anterior of the cingulum plateau of the upper incisors. Now, this is according to the British Standards Institutes of Incisor Classification. So, therefore, it may have a reduced overjet, positive overjet, or a frank reverse overjet. Now, the molar class 3 relationship is when the mesiobuccal cusp of the upper first molar occludes posterior to the buccal groove of the lower first molars, and this is according to Engel's definition. Now, what are the etiological factors that come into play in class 3 malocclusions? Now, heredity plays a major role in the inheritance of a class 3 jaw pattern, and a very famous and good example of this is the Habsburg jaw, whereby many members of the Habsburg dynasty had this mandibular prognatism. Now, the second factor is a soft tissue factor or a functional factor. Now, the tongue is usually low and it may be anteriorly positioned. There may or may not be macroglossia. Together with may or may not be enlarged adenoids. And in a functional etiological process, there's habitual protrusion of the mandible in a forward position. Now, the third factors are a group of factors are the dental or local factors. This may be due to occlusal prematurities, which cause the mandible to slide into a cross-bite relationship, and an abnormal eruption pattern whereby the upper incisors may be deflected lingually into a cross-bite. Now, there are also pathological causes of class 3 malocclusion, and this can be due to things like condylar hyperplasia, any of the craniofacial syndromes, including cleft lip and palate, whereby the growth of the maxilla is restricted or stunted. Equally, a trauma to the mid-face can also cause retardation of growth of the maxilla. Now, we can classify class 3s according to two schemes. One is whether it is a true class 3 or a pseudo class 3. Now, pseudo class 3 is whereby it's not really a class 3, but because of occlusal discrepancies, the mandible displaces forward into a class 3 relationship. Now, the other way of classifying a class 3 is whether the malocclusion is skeletal or it is dental. Now, what are the clinical features of a skeletal class 3? Now, the extraoral features are usually reflected in a concave facial profile, and this concave facial profile happens either because the mandible is large or prognathic, or the maxilla is small or retrognathing, or it may be a combination of the both factors. Here is an illustration whereby A demonstrates a normal um, uh, dental class 3. As you can see here, the incisors are in a class 3 relationship, but the dental bases are in a normal class 1 relationship. Now in B, what we see is a maxilla that is set back from the normal ideal position, and in C we have what a mandible which is forwards of the normal position, and in D it is a combination of both whereby the maxilla is set back from the normal position and the mandible is displaced anteriorly from the normal position. Okay, students should learn to recognize facial profiles. Now, the ideal facial profile is what is known as a straight facial profile, and in class 2s what we see is a complex convex facial profile, whereas class 3s tend to have a concave facial profile. Now, facial divergence is only relevant to a straight profile. The profile may be straight, or it can be divergent posteriorly or divergent anteriorly. Now, what are the intraoral features of a skeletal class 3? In a skeletal class 3, you may get a class 3 molars, canines, and class 3 incisors. Okay, when we mean a class 3 incisors, is not just a reverse overjet, it can be a edge to edge incisor relationship, or it can be a reduced positive overjet whereby the lower incisors are occluding forwards of the cingulum plateau. Now, there may also be a crossbite due to a narrow upper arch. This happens when the maxilla is retrognathing and small. Now, what are the features of a dental class 3? Now, extraorally, a dental class 3 can appear with a concave facial profile or a straight facial profile. Intraorally, they tend to have class 3 molars, though not always. Okay, they tend to have, they may have class 3 canines, and they also have may have class 3 incisors. Okay, now here the class 3 incisors are divided into 3 types. Okay, whereby class 1 is with a reduced overjet but still positive overjet. Class 2 is where the incisors are edge to edge, and in class 3 there is reverse overjet. Now, the intraoral features of a dental class 3, we tend to find crowding in the upper arch, because frequently in a class 3 malocclusion the upper jaw is small, thereby the dental arch is small and narrow and tends to give rise to crowding. Now, the other feature we tend to see is what is known as a dental compensation. Because the lower incisors are more forward placed, they tend to become retroclined, whereas the upper incisors which are backward placed tends to procline in order to bring about dental compensation. Okay, the cephalometric features of a class 3 malocclusion. Now, the maxillary to cranial base relationship, or the SNA, is normal or reduced. It is reduced if the maxilla is retrognathic. The mandibular relationship to the cranial base, represented by the SNB, it may either be increased or normal. It may be increased if the mandible is prognathic. Now, the maxillary mandibular relationship, represented by the A and B, is reduced, okay, and the width measurement usually shows more than 0 millimeters, whereas the norm for males is negative 1 millimeter, and for females it is 0 millimeter. Now this is the width measurement, whereby the a perpendicular is dropped from the A point to the occlusal P. Similarly, a perpendicular is dropped from the B point to the occlusal plane, and then the distance between these two, the AO and BO, is measured. Now, because of the proclination of the upper incisors, the upper incisor to the maxillary plane angle is increased, and because the lower incisors tend to be upright or retroclined, the lower incisor to the mandibular plane angle tends to be normal or reduced. Now, a word about facial growth in class 3. Now, usually continuing facial growth in class 3 cases are usually unfavorable. The maxilla completes growth earlier than the mandible, and any continuing growth mainly affects the mandible, and the mandible tends to become prognathic. Now, if the patient has an age to age incisor relationship, this will tend to become worse or becomes a reverse overjet with continuing growth, and similarly a reverse overjet tends to get worse with continuing overgrowth. Now, if there's also vertical growth occurring in the mandible, then this may give rise to a skeletal open bite. Okay, now if you look at this growth, compare the growth in the maxilla and the mandible. Okay, this purple curve is the growth of the mandible in the female, the blue curve is the growth of the mandible in the male, and this broken red line is the growth curve of the maxilla. As you can see, the mandible undergoes a growth spurt at the time of pubertal growth spurt, females being earlier than the males. Okay, and with this continuing growth, any differential growth favoring the mandible will result in the mandible becoming more prognathic and resulting in a class 3 malocclusion. Okay, let's have a look at management of class 3 malocclusions. There are a few factors that we need to keep in mind when managing class 3 malocclusions. Okay, one is the patient's concern. Now, the class 3 malocclusion may be dental or skeletal, and what you treat will depend on what the patient wants. Okay, and the second factor influencing treatment is the severity of the skeletal discrepancy. Now, the severity will decide whether a particular case can be managed just with camouflage orthodontics, or it has to be treated with orthognathic surgery. Remaining or residual facial growth is a factor to consider, because any class 3 relationship that has been treated before pubertal growth will relapse. Ones that are not treated will tend to get worse. Now, the degree of dentoalveolar compensation is also of important factor to consider, because if the dental arches are already compensated, then it is difficult to correct the treatment with just corrective orthodontics or camouflage orthodontics, because there is no more room to compensate further. Now, depth of overbite is an important consideration in the stability of the final treatment. Now, adequate overbite will ensure that the any crossbite or reverse overjet correction remains stable. Now, what are the benefits of class 3 treatment of class 3 malocclusions? One, of course, obviously there will be an improvement in dentofacial aesthetics. Now, if there is a mandibular displacement, correction of the mandibular displacement may eliminate the adverse effects of displacement, such as attrition of teeth at premature contact sites, prevent temporomandibular dysfunction, and also relieve strain of the lower incisor periodontium in the presence of anterior crossbite. Now, masticatory function is improved with treatment, and also obstructive sleep apnea may also find improvement when the class 3 relationship is corrected. Okay, the treatment plan for class 3 malocclusion. Now, when we are treating class 3 malocclusion, the first thing to consider is whether the patient is growing or whether it's a not growing patient. Now, in either of these category, we will have to decide whether the malocclusion is basically skeletal or is it dental. Now, if the malocclusion is skeletal in nature, then in a growing child, the modality of treatment will be some form of orthopedic intervention. Now, exactly which one will depend on which jaw is at fault. Now, if the maxilla is small, then the orthopedic treatment aims to protract and stimulate the growth of the mandible. If the fault is with the mandible, then orthopedic treatment is directed towards restricting mandibular growth. And in case situation where it is both at fault, then a combination of both is used. Now, in a non-growing patient, we don't have the luxury of growth modification since growth has ceased. So, in severe skeletal cases, we will need to resort to surgical correction, whereby if the maxilla is fault, the maxilla is surgically advanced, and if the mandible is at fault, then the mandible is surgically set back. Now, in non-growing patients with mild to moderate class 3 bases, orthodontic camouflage can be carried out with extraction of teeth. Okay, now management of class 3 malocclusions in a pre-adolescent child or in the early mixed dentition. Now, if there is any retained primary incisors which is causing the permanent incisors to be deflected lingually, then this primary incisors should be extracted. Okay, and if there is an anterior crossbite associated with forward mandibular displacement, then this should be corrected early to prevent worsening of the class 3, and this can be easily be done by proclining the upper incisors with a URA, carrying a Z spring or a screw, or with simple fixed appliances such as the 2x4 appliance. Okay, in the late mixed dentition, we could use a retrusive face mask to correct a retrusive maxilla. We can use a protraction face mask combined with rapid maxillary expansion, because we must remember the maxilla is, when we say the maxilla is small, it is not just in the AP direction but is also small in the transverse plane. Okay, and this can be accomplished with either a Delaire face mask, a Petit face mask, or any other face mask like Gramont's face mask. There is also a option of protracting the maxilla using bone anchored screws. Okay, if the mandible is at fault, the mandible is prognatic, then mandibular growth can be restrained orthopedically by using a chin cup in combination with a headgear. Now, in the late mixed dentition, a functional appliance can be used to correct the class 3 skeletal relationship, and these functional appliances can also be used as a retainer after the orthopedic treatment, since uh, uh, the retention has to be carried out until growth has ceased. Now, the examples of myofunctional appliances available to treat class 3 are the function regulator of Frankel 3, the reverse twin block, or a class 3 bionator. Now, in the permanent dentition, if it is mild to moderate class 3, then camouflage or corrective orthodontics can be carried out, whereby the upper incisors are proclined and the lower incisors are retroclined, and space for doing this can be obtained by extractions, either extractions in the single arch or both arches. Now, what are the indications for camouflage or corrective treatment? One is the patient should be past the peak skeletal growth, that means past the pubertal growth spurt. There should be no pre-existing dentoalveolar compensation. Patient preferably should be able to achieve a edge-to-edge incisor relationship, and there should be an adequate overbite with a normal or slightly reduced lower facial height, and the skeletal relationship should be mild or moderate. Now, management of class 3 malocclusions in the adults. Okay, now if it is mild or moderate, then the management is same as in the permanent dentition. Now, if it is severe, and since these patients are non-growing, the only feasible modality of treatment to correct this skeletal relationship is to do orthodontic surgery, and basically orthodontic surgery aims to set back the mandible and advance the maxilla. There is also can be undertaken with distraction osteogenesis. Now, relapse in a correction of class 3 is usually caused by an inadequate overbite post-treatment to maintain incisor relationship, and there is continuing unfavorable growth, which in the AP direction tends to cause relapse of the overjet correction. Thereby, retention is necessary until growth is completed. Okay, these are the references for today's lecture.